Uh, Good afternoon, everyone. And by my reading, it is just barely seconds or 1 minute into afternoon, so good afternoon. And thank you for joining us for this timely event. I'm Fred Kemp. I'm President and CEO of the Atlantic Council. Today's discussion, National COVID-19 Testing Action Plan, Rapid Scaling will drive resilience. Rapid scaling will drive resilience. It is hosted by the Atlantic Council's Adrienne Arsht Rockefeller Foundation Resilience Center, and is one of a series of recent events we've been holding on COVID-19, the solutions and strategies to overcome the crisis. Clearly, the crisis has put us in this situation of telework and digital connectivity, but we have found in many respects we can be even more effective in building a community around a very good idea like this one. The Adrienne Arsht Rockefeller Foundation Resilience Center is focused on implementing actionable solutions and scalable solutions toward the goal of reaching 1 billion people with resilience solutions by 2030, with a particular emphasis on climate issues, migratory issues, and of course, public health issues. I want to thank two people who have made this center possible. Atlantic Council Executive Vice Chair Adrienne Arsht. Her interest in resilience and her vision and energy set us on the path to building this very important center. And of course, to Dr. Raj Shah. Raj, as president of Rockefeller Foundation, thank you for your partnership and your unwavering belief, which is inspiring us all to serve the most vulnerable among us, particularly in these times. Today, we're going to focus on the Rockefeller Foundation's National COVID-19 Testing Action Plan. It was launched last week on the precise steps necessary to enact robust testing, tracing, and coordination to safely open economies, and particularly the U.S. economy. Just 2 weeks ago, Raj joined us on a call with Nobel laureate Paul Romer to talk about this idea of a national testing strategy. Paul yesterday was quoted in the Washington Post about how it would only take $100 billion or so to test everyone in the nation once every 2 weeks. That used to sound like a lot of money, but when the Congress is spending $2 trillion so far to keep the economy going, it sounds like not so much to me. And he's optimistic about the possibility to scale up. I'm not going to introduce the speakers. Jillian Ted is going to do that, but I'm absolutely delighted that we have Mer Suarez and Dr. Pellini and Raj to talk about all this. We're going to focus on the strategy laid out in the report during this conversation, and the plan, and discuss how we can achieve the outcomes to protect and reopen the economy. So let me turn to Jillian Ted, one of the journalists I respect most in the world and a good dear friend of the Financial Times, to introduce our speaker and to guide our conversation. At the end, Cathy McLeod, the remarkable leader of the Arsht Rockefeller Foundation Resilience Center, will close the session. Jillian.
Well, thank you very much indeed, Fred. And we are indeed living in a very peculiar world where $100 billion looks positively cheap at the price, if that is indeed the way we restart the economy. And the reality is that in the last few weeks, we've learned that many of the other potential tools we have to restart the economy simply are not going to be good enough. I mean, throwing massive amounts of central bank cheap money, throwing stimulus packages, presidential decree, all these things that traditionally people have tried to use to restart an economy aren't going to work, and waiting for a vaccine is going to take a very, very long time. So testing is absolutely top of the mind of not just journalists like myself, but almost any citizen right now, as well as business leaders who are looking to restart growth and local government officials. The question, though, is how do you actually go out rolling it out? How much would it cost? How practical and easy would it be to implement? And can we actually deal with the real medical challenges? Because we've all become armchair epidemiologists recently, but most of us, frankly, don't have the foggiest idea of what it actually means to get testing out in a practical way for everybody. So we have an amazing group to talk about that. We have Raj Shah, who took part in a webinar I moderated recently with Paul Romer to talk about, in general terms back then, what the Rockefeller Foundation hopes to do to promote the idea of testing across the nation. And so I'm going to be asking him to talk about how that's actually going to work out in practical terms. Dr. Pellini, who is a renowned expert in this field as a medical expert and academic, which means that he, unlike many of us who are pontificating these days, actually knows what he's talking about in medical terms. So he's going to explain the practical aspects of this from a medical perspective and explaining how he's helping the Rockefeller Center to turn some of these big words into practical actions. And then we're particularly honored to have Mer Suarez, the mayor of Miami, join us today, who is coming to this issue from a very personal perspective. He, in fact, suffered from COVID-19 in March and is now thankfully recovered. So we're delighted to see you today, Mer Suarez, and is now facing the very real on-the-ground problem of how do you take these big plans and the medical science and turn it into reality to protect a city like Miami. So I'd like to start with Raj Shah, Dr. Shah, and say, what exactly do you plan to do or hope to do with the Rockefeller Center's muscle and largesse?
Well, thank you so much, Jillian. It's nice to be with you and to all of you that have joined for this conversation. Particularly special thanks to Fred and of course our partner at the Rockefeller Adrienne Arsht Center at the Atlantic Council, Adrienne Arsht, who is also joining us today. I'm glad to be on with Francis and Mike because I think they both have extremely practical, pragmatic management strategies that will inform us an approach for our country to actually scale up testing dramatically and use that testing scale up to allow us to safely reopen parts of our economy. And that's ultimately what we tried to do with the Rockefeller Foundation Action Plan. We brought together a group of scientists, industry experts like Mike, mayors and governors who we work with and have worked with for a long time, like Francis Suarez and so many others, and tried to understand, are there a set of practical, pragmatic actions our nation can take to scale up testing? And the reason we focused on testing was it really is the only way out without having a vaccine or an easy therapeutic, neither of which seem readily available, to reopen parts of our economy and avoid the ricocheting between either being fully shut down and therefore safe, or being active in the economy and therefore at tremendous risk of rebound COVID-19 pandemics. And when we looked at the data, we identified a set of targets that I think are quite instructive, and we call our plan the 1-3-30 plan to make it really straightforward. Right now, America is stuck at about 1 million tests per week. We've been stuck at that level for the last 3 weeks at least, and it's not scaling up fast enough. To safely reopen parts of the economy for essential work, we believe we need a minimum of about 3 million tests per week, and we think that's achievable in just 8 weeks. And I know Mike Pellini will describe why, but it centers on the basic observation that 2/3 of America's molecular testing capacity resides in university labs, research labs, and small labs that are really not part of the national CDC diagnostic and surveillance system. And that molecular testing capacity needs to be brought online urgently. And those labs need to be a part of the strategy to get us from 1 to 3 million in just 8 weeks' time. We've also proposed going from 3 million tests per week to 30 million tests per week within a 6-month window. And to get there, we're going to need some new technologies, point of service tests, home kits that enable us to take the test much more regularly. And we believe there's a role to play to accelerate those technologies. But it's also critically important that we bring together the somewhat fragmented and cottage industry that is the lab sector in America and allow them to do things like procure product in pools as opposed to on their own. And that we, being the federal government, philanthropies, major American banks, come together and provide those purchasing orders or purchasing contracts enough financial security in the form of financial guarantees so that we can actually reshape the plans and procedures that suppliers or test kit manufacturers have in terms of what kinds of volumes they can supply to the industry over the course of the next many months. And without that really important step function increase in the manufacturing and distribution of the critical supplies to backstop this strategy, we don't think it will succeed. And that's why the Rockefeller Foundation, together with a number of other partners, public and private, is working with urgency to create an emergency network for COVID-19 testing and supplies. We're working to work with partners on the ground to expand the creation of a contact tracing workforce so that anywhere from 100 to 300,000 Americans can be hired into a community health corps and actually use the data that comes from expanded testing to identify who's at risk and pursue and enforce and encourage self-isolation and more precision quarantine methods. And we're working with partners to build a data commons, really building on existing efforts, but trying to create a national data platform so everyone everywhere can see where are their labs with extra tests, what are the important experiments going on in American institutions with respect to testing protocols, and what's the data on different types of tests and equipment and supplies so we can make more informed national decisions. I guess I'll close this opening comment with just an observation. When I led the West African Ebola response with I'm sure many of you on this call, the United States deployed the US military at tremendous scale. And our top priority was getting the timeline to get a confirmation of a positive diagnostic test down from 8 or 9 days to inside of 4 hours. And in that moment, America threw every resource we had at that 4-hour task. We had American helicopters transporting blood samples in rural Liberia. We deployed military bioterror labs because we needed the capacity. We trained and hired community health workers in the thousands and got them protective equipment so they could be part of a collection and contact tracing effort. And ultimately, when we hit that target of getting a result within 4 hours, we saw a steep and rapid decline in the Ebola crisis, so much so that most of the capacity we had built to treat Ebola patients went completely unused. And I would argue that should be our goal here in the United States. If we know that testing and contact tracing is really everything until there's a vaccine. And so we should be doing everything we can, public and private, state, federal, and local, in collaboration to achieve that goal.
Thank you, Dr. Shah. And that's an incredibly inspiring rallying cry, because heaven knows we all need examples from history which shows what can be done. There aren't that many from within America's own history at the moment that we can look to, but that's certainly a very, very inspiring. So I'd like to turn now to Dr. Mike Pellini. You're actually on mute, so you may need to unmute your line as I quickly introduce you, because you're in a very interesting role and you have a lot to say on this topic. You're working with the Rockefeller Center to try and bring this out, but you are a trained physician. You have been in medicine for more than 20 years in a series of senior roles at different companies involved in clinical diagnostics and genomics. I won't run through your extremely impressive biography, but you have basically seen what it's like in the private sector to try and roll these types of responses out. How realistic is it going to be from a medical perspective to actually get this done?
Well, Jillian, I think with a well-coordinated effort, it is very realistic. And before I dive into that question, though, I'd just like to take a moment to thank the Atlantic Council for the invitation to speak today. And frankly, it's an honor to be on this virtual panel with Dr. Raj Shah and also Mer Suarez. And in terms of Mer Suarez, I'll tell you, there's nothing like an upfront encounter with something, a firsthand experience to really shape one's experience. And I certainly look forward to hearing those comments. One of the challenges that we're facing is that this is an industry, the diagnostic industry is one that has in many ways been left behind, at least from a policy standpoint, from a payer standpoint, from a regulatory standpoint for decades now. And so when this COVID crisis hit, to ramp up diagnostic testing, we weren't starting the game at 0-0. we were in fact behind 28-0. And we had to catch up before we could even make progress. And a couple of data points that I'd like to share with you in the audience, because I think these are certainly underappreciated data points. Diagnostic testing in the United States accounts for about 1% to 2% of our overall spend, our overall health expenditure. Yet diagnostic testing guides 80% of medical decisions. And in this case with COVID,
Wow.
where it's no different. And oftentimes I hear the question about, well, why is this so important medically? And I think we should reframe the question as we consider scaling from 1 to 3 to 30 million tests. It's not about just medicine. It's about our overall nation's health. Let's not think about an individual's health. Let's think about the nation's health. And the nation's health is certainly medical. That's one of the things we do, in fact, need to focus on as individuals, as populations. We need to focus on our economic health. That's critical. We need to focus on the political health of the nation. That's another element as well. But there's one other aspect that we must focus on here as well, and that is, frankly, our emotional well-being. And all of these challenges come back to our need to ramp diagnostic testing. I just want to spend one moment on that last piece, the emotional well-being as well. I am a 54-year-old physician. I understand this virus reasonably well as I think, probably better than a lot of folks, especially a lot of lay people. Yet, if I spike a temperature, I want to know if I have this virus. And even for me, it's extraordinarily difficult to be able to do that. If one of our family members, if a child, if a grandchild was exposed to somebody potentially with a virus, we want to know if our child, our grandchild was exposed, even if they're asymptomatic. I have an 89-year-old mother who lives alone. She's remarkably healthy. Yet she has 3 sons. We can't see her because we are unable to get quick tests and repeatable tests to make sure that it's safe for us to do so. And so the only way that we overcome these challenges, these business challenges, these political challenges, these medical challenges, these emotional challenges, is to scale testing and do it very quickly in this country. And if we focus on the appropriate steps, we will be able to get there. And let's keep in mind, unlike the vaccine challenges, unlike the therapeutic challenges, the diagnostic challenge is not necessarily one of innovation. It's not one of research. It's not one of discovery. It's actually one of coordination. It's one of financing. It's one of partnership, both partnership between organizations, public-private partnerships. And so reframing the challenge, it's not about true innovation. It's about coordination, partnership, and financing. And that really gets to the heart of the issues that we're focused on through the Rockefeller Foundation. So if we can financially backstop these laboratories, these public health and public health organizations to be able to procure long-term supply agreements without having to worry about their financial exposure, that checks a significant box. If we are able to centralize decision-making within states or within regions, which is what the rest of the world is doing, that checks a significant box in how we ramp. Today, we have thousands of laboratories and thousands of organizations fighting with one another to see if they can get swabs, to see if they can get kits, to see if they can get various reagents. That's not going to work if we simply continue down that path. And the final thing, as Raj mentioned, I'll repeat, is one of the reasons that we need better access to data is because within any given state, within any given region, there are laboratories that have excess capacity of 80%. They're only receiving 20% of the tests that they could actually run in any given day. Yet right next door, there are laboratories with turnaround times of 5, 6, 7 days, and they've tripled their capacity. They might be 30 miles apart from one another. So what's happening? What's happening is that the providers, the healthcare providers who are ordering those tests, don't have visibility into the system. So if as a third component of the plan, as we generate this information and we develop local dashboards to match up capacity with demand, truly on a daily basis, which, by the way, is the way that most organizations in the world function, we enable these healthcare providers to make appropriate real-time decisions so they know where to send the samples. And in fact, we believe we can do that in an automated fashion. So if we focus on, if we get into the weeds, which is where we have to get to with laboratory tests and the way this industry is structured, we can start to peel things off one at a time, focus on financing, focus on centralization of decision making, and focus on dashboards so we can make appropriate decisions. We will see a dramatic uptick in testing in the United States.
Well, thank you very much indeed, Dr. Bellini, for that very rousing description of how we need to take essentially what's a cottage industry right now, a large cottage industry, but still a very fragmented cottage industry, and turn it into a professional army almost overnight. And you say a lot of that's going to be about execution and collaboration and organization and trying to use private sector initiative in the most effective way. So I'd like to now turn to Mer Suarez and ask you, I think you may still be on mute, so again, we may need to unmute quickly, ask you how it looks on the ground from the perspective of someone who's running a vibrant, wonderful city that we all hope gets back to normal as soon as possible so we can have a vacation at some point. And in particular, I'm curious, I mean, you had COVID. I hope you're now doing better. How did you get a test? How did you find out that you've been infected? And what can you do to roll out that experience across your region?
My experience is interesting because it really is instructive in terms of all the things that we've discussed on this panel. Our story begins even before I contracted COVID-19, which was on March 13th. Our fire chief actually identified this threat when it was in Wuhan during the Super Bowl and started ordering personal protective equipment and equipment to decontaminate our rescue vehicles at that time in early February. So he was really trend-setting and really understood how this epidemic could turn into a pandemic, which could impact how we delivered services every single day. I actually had an interesting experience because I was receiving a delegation from Brazil, with the president of Brazil, who had been with the president of the United States the weekend before. And it became public later that week on March 12th that one of the members of that delegation had tested positive for COVID-19. You have to understand, you have to take yourself back to that time. This was really at the beginning. And it's so much so that on March 12th, the day that I found out that I was in a room with someone who had been positive a few days before, I had to make my state of emergency declaration remotely because my fire chief and our medical director had asked me, and I had obliged to voluntarily quarantine myself immediately upon understanding and realizing that I had been in close contact, close proximity with someone who was COVID positive. I was completely asymptomatic. So to Dr. Pellini's perspective and points and Dr. Shah's, I was completely asymptomatic at the time. Because it was so early, and you have to understand that in Miami-Dade County, which has a population of 3 million people, there was only one person at the time that had tested positive, one person. And so I was asked by the Florida Department of Health to go in and get tested, unprompted. And so I did on that day. And I woke up the next day with absolutely zero expectation that I would test positive. And got that phone call and was told that I tested positive. And I remember specifically asking the doctor, who's an epidemiologist for the state of Florida, are you certain? And he said, well, I'm about 98% sure. And I said, no, you don't understand. I need you to be 100% sure. He said, I'm 100% sure. So, because I understood at that moment the ramifications of what being positive as a mayor of a major city would mean, not only for myself on a personal level, but certainly for my family, for the government that I run, and for all the people that we serve. So immediately I had to go public. I went public within essentially the hour from finding out after notifying my family. And I became probably the first elected official in all of the United States that had diagnosed positive. The second case in Miami-Dade County, and a little over a month after, we had 11,000 cases and over 300 deaths in our county. And that's understanding that we were the first city to implement we were the first city to cancel large events in the United States. We were the first city in Dade County, or second city, to implement a stay-at-home order. And I would have implemented it earlier had my city attorney allowed me to. We were the first city to implement a curfew. We were the second city to require masks to be worn in grocery stores, supermarkets, banks, construction sites, not just by the employees, but also by the patrons of those establishments. So we were as proactive as we possibly could be. Having said that, we still led the entire state in number of cases. And the city's proactivity allowed us to outperform Miami-Dade County, which followed and lagged on some of these major decisions that we were making. Obviously, the fact that I was asymptomatic and got tested really, for me, highlights the need for broad-scale testing. Had I not been tested, I certainly would have infected most likely my family, because you have to understand, taking yourself back to the 12th and the 13th of March, we didn't even have social distancing norms in place. We didn't have stay-at-home orders. We didn't have any of those things. So I certainly would have infected my family, and I probably misinfecting them by a window of a day or two, when my symptoms began. And I certainly could have infected multiple people in our government, which would have created potentially a mass contagion throughout our government that would have affected our ability to provide services to 750,000 people, or 1 million people, depending on our daytime population. So I'm the prototype for asymptomatic testing, since, thankfully, we actually did, by the way, test asymptomatically about 40 members of our government that were in close contact with me, and all tested negative. So, but for the actions of our medical director, our fire chief, our emergency manager, the Department of Health, being proactive when I was in the room with and potentially in contact with someone who had COVID-19, I could have infected hundreds, if not thousands of people unknowingly. And so I think that is the challenge that we have to confront as we come out of the back end of this. I've been criticized. I was criticized when I acted proactively on the front end, and I'm being somewhat criticized right now for not opening as quickly as our county, which just decided to open parks and their marinas. And part of the reason why is because I want to let the scientists and the doctors drive our decision making, and B, because I have a tremendous fear, being asymptomatically positive, that we can go back from the declining new positives that we're seeing day in and day out, right back to where we started, knowing that we went from 2, which I was, to 11,000 essentially in a month. And so what I hope is that it doesn't take that kind of resurgence or rebound pandemic for us to have to make some of these decisions to get that mass and widespread testing going. We were the first city to do in-home testing. We did that for the elderly and for the vulnerable in our community. We are now doing asymptomatic testing, but it's not at the level and at the broad scale that is really necessary for us to safely be able to contact trace and to be able to get back to work with full assurances that even with the regulations that we implement, that people are not at risk. And so those are the things that we're weighing, and we have been as proactive as we possibly can. But I think it's wonderful to be on with Dr. Pellini, with Dr. Shah, Raj, and with Adrienne, and certainly Fred and the Atlanta Council to be here with you all discussing these very important matters as we move forward.
Well, thank you, Mer Suarez. And I think everyone on the call is delighted to see that you are well or healthy. And in many ways, your own personal story is not just a very salutary one. Everyone is watching and listening. And I'm curious though, give us a sense in Miami right now, if you want to get a test.
I'm having a hard time picking up your audio, so I'm not sure that I understood the question.
Sorry. The question was,
I think we've
this
lost
is Jackson,
Jill-
the Atlantic Council AV Manager. Jillian, I'm sorry. We're unable to understand your audio currently, so we're going to pass over to Cathy while we work through your troubleshooting. Stand by.
Hi, good afternoon. I'm Cathy Baughman McLeod, and I lead the Adrienne Arsht Rockefeller Foundation Resilience Center. And while Jillian's audio gets straightened out, let me kick off the section where we want to hear from Dr. Pellini and from Raj and Mer Suarez about the plan itself and what do we need next. And so maybe, Raj, I'll just come back to you and say, you've put a plan forward, there's a price tag on it, there are all sorts of issues, you've got a team of contributors to the report and a plan. What's next and what do you need?
Well, thank you, Cathy. I think, you heard very compelling comments from both the mayor and Mike. And at the end of the day, we have an action plan that has some core components. The first is we do need the federal government, we believe, to adjust its reimbursement for tests so that it applies to labs that are in network and labs that are out of network, including the underutilized, research and the small institutional labs that exist in our country that are holding a lot of that capacity that's not currently being fully tapped. I think a second thing we have suggested and Mike spoke about in some detail is we need to have a emergency procurement facility so that labs and cities and states can come together and place larger, longer term purchase orders with some financial backing from banks, from foundations, ultimately from the federal government. So we take the risk out of placing larger long-term orders, and so that manufacturers of these critically needed supplies can understand what the actual need and demand is. Maybe not in the next few weeks, but in the 3-month to 12-month window, so they can make investments now to scale up their capacity to manufacture a whole lot more critically needed supplies in that window. We've been very specific about the need for a contact tracing workforce, because ultimately the data on who's positive from an expanded testing effort needs to be fed into a public health system where people who are trained, who know how to keep themselves safe, can interact with those who then either need to be isolated, self-isolated, as Mayor Francis kind of gave personal testimony to, but also to those contacts of those who present some risk, both for further testing and precision quarantine or precision isolation, so that everything in a community doesn't have to shut down. You can just identify those at risk and have them take themselves out of potential circulation, so to speak. We have proposed the workforce piece, by the way, we've proposed enabling certain authorities in federal government. That the Corporation for National and Public Service, for example, has 75,000 service members, many of whom have been idled. The Peace Corps has 7,000 who have been returned home. The Corporation for Public Service actually receives 5 or 6 times the number of applicants for every one that it hires. So it has a standing database of people who are interested in serving their country. In the Ebola fight in West Africa, we actually used the military with a group called Médecins Sans Frontières, a public health NGO, to train community health workers so they could be contact tracers and do the work that needed to happen in communities. We could, the Yale School, a number of schools out there have training modules. We could have a standardized and large scale training, but we need to stand up that workforce, and we propose the federal government should pay for it. We also have proposed this national data system so that every decision maker everywhere can kind of tap in and see
Mm.
Are there enough tests happening in a particular place? Where's the capacity constraints? How do you how do you direct tests to places that have more capacity to get quicker results, along the lines of what Mike talked about? So these are all really specific actions, some of which we're starting to already see take place in the bill that was passed just recently. Because there are ongoing stimulus and response pieces of legislation, it is my hope that this can move relatively quickly. And the $100 billion price tag, which, at the time felt perhaps like a lot, we've already made a $25 to $30 billion initial investment. The $100 billion is for the whole year. About $80 billion of it is in the $100 per test reimbursement structure we've proposed. And the rest is for the workforce effectively. So we feel like the country is going to and needs to spend this resources. Now it's about doing it well and doing it in a coordinated way, and overcoming the challenge of what is otherwise a very disaggregated industry.
Yeah, it feels like we can't afford not to. I'm going to pass it back to Jillian Tett. I think we've resolved those issues. And back
Well,
to
I
you,
hope so.
Jillian.
I hope so. Can you all hear me well?
Yes.
Good, great. I should also say before I ask the next question that if anybody who's watching wants to ask a question, do please send it using the Q&A function, and I will incorporate it into our discussion, hopefully without the same Wi-Fi garbles and glitches. But I'd like to quickly turn to Mer Suarez and say, what is the current situation on the ground in Miami if you want to get a test tomorrow? If you're an ordinary person who says, I want to get a test, can you or can you not? And how do you imagine it would work to, say, mobilize the Peace Corps or the Reserve, National Reserve, or someone like that to try and get this done? I mean, do you think that you could actually implement in your own backyard what Dr. Shah is talking about?
Yes, we think we can. Right now, if you are symptomatic, you are essentially guaranteed a test for free, and you'll get it essentially next day. We now have gotten to the point where we are sort of graduating from symptomatic testing to asymptomatic testing. That's not something that's happened up until this point. I think the second part of it is we also have to test people who have already tested positive. I mean, I was fortunate. I took, I think, 7 tests in the time that I was quarantined. I took 5 antigen tests and 2 antibody tests. I was kind of a guinea pig, and they were using these tests to see if they worked. Some of them they did, and some of them they weren't happy with. And so we didn't large scale procure some of the tests based on some of the results that I showed. So I think there's what I call front end testing or asymptomatic testing, and then what I call back end testing, which is people who have already tested positive, but either want to donate plasma like I did, which has also been somewhat effective, at least in some of the cases that I've seen of people who have actually transfused plasma and have actually beaten COVID-19 and have come out of a convalescent intubated state and are now recovering. And I think also, for people that have tested positive, they want to have a reassurance, and their employers, I presume, will want to have a reassurance that they're not going to negatively impact anyone. And so I think we have to look at asymptomatic testing and symptomatic testing where someone has already tested positive and wants to have some assurance that they're negative so that they can either donate plasma or go back to work. We right now have the capacity to test hundreds of people on a daily basis in the city. We can probably ramp up because, to be honest with you, none of our facilities were ever completely at max capacity. But I think what Raj is saying is incredibly important. If we had the federal backing, if the federal government said, hey, we're going to reimburse you for tests at a level of $100. By the way, we're getting test results from labs at $50. So if we got a $100 reimbursement, it would be even better. And of course, all the employees that are needed to staff up these testing centers, then we would absolutely be able to test at a much, much greater scale and be able to get results back fast. And of course, at some point we hope that there are, and I'm sure Dr. Pellini and Dr. Shah have much better information on this than I do, but having accurate antibody testing and rapid testing would be something that we would be fantastic. I mean, it would streamline the process tremendously, and I just don't know where we're at on that, and I'd love to hear their perspective on that.
Well, we're getting some great questions already on those points. I must say, being cynical, that if you had been able to turn your whole experience into a reality TV show with your testing, that probably would have done more to kind of transmit the message to the wider public and perhaps even to the White House than anything else that we could or should say today.
My wife didn't let me. My wife didn't let me, even though I did journal about the days that I was in quarantine, and I did get a lot of feedback.
I'm sure it did, yes. But Dr. Pellini, I'm curious. We got a question I'm going to throw to you straight away, actually, from Kevin Ryan, who's watching, who said that if testing is moved into the research laboratory setting, how will CLIA level standards of lab quality be measured and maintained? Perhaps you better start by translating what CLIA level standards actually mean.
Sure, I'm happy to do so. Before I do so, I just want to come back to Mer Suarez's comments, and I am stunned. You are, in fact, you've been a guinea pig for, and perhaps an incredibly educational way for all the challenges that we are facing. What you describe and what you've directly encountered is what we're working on as a nation now to fix. And so your perspective and your experience is greatly appreciated. And it's just remarkable to hear the number of comments that you've been able to put forth just from your own firsthand experience. So our industry, the laboratory industry, has regulations. There are FDA regulations, which are the regulations for many of the kits which are used to perform the testing. And then each laboratory that is allowed to run kits or run these tests they would be accredited by an organization under the Center for Medicare and Medicaid Services, and this is a CLIA accreditation. So in order to be able to perform a test that will be reported back to an individual, the laboratory must be CLIA accredited. So the question is, well, what if it's a test run in a research setting that is not CLIA accredited? It's a good question, and there is some. I know there are some questions going both into the FDA as well as the CMS to basically suggest that if an R&D facility, if one of the major, let's say, sequencing centers in the United States has the ability to run 100,000 or hundreds of thousands of tests per day, which is a possibility in the coming months, and they are not CLIA certified, what can we do to I guess, increase the speed at which they can actually be allowed to perform clinical testing? That's something that we're focused on right now. We don't, as a nation, we don't have an answer to that. But I'll tell you, I will express optimism that working together between the FDA and CMS, that we will find a solution there by the time we need it. I'd also encourage everyone to not focus on just innovative new approaches. That is an essential element as we continue to scale, maybe to hundreds of millions of tests that are available. But in the interim, there are some very basic things that we can do and that we must do. As Raj said, we have the major laboratories run about 40% of what are called molecular tests, of which COVID PCR test is one. They run about 40% of the tests in the country right now. There are 60% of laboratories that have the ability to run COVID testing, and they may be running it, but they're not part of the network. If we can bring them online overnight, we increase our tests available by 2.5 times. So just by doing that, we go from 1 million tests per week to 2.5 million tests per week. Clearly, we can't do it overnight, but we can absolutely do it within this 8-week window. The second thing is point of care tests. We've heard about them, and they are being deployed, but we must continue to be aggressive with point of care testing. So these tests can be much more widely available than they are today. And the third part of the near to midterm solution has to do with home tests. We are fortunate in that there were some companies that were relatively close to being available for commercial utilization before COVID hit. Now, we didn't have an effective PCR molecular test that was ready for home use, but thanks to some of the work that BARDA, which is one of the federal funding agencies, has been able to support over the previous months, and also some ingenuity with a number of companies, we are getting very close to these home tests actually being widely available. And so again, there's a regulatory challenge, there's a reimbursement challenge, but let's not lose sight that this is not an or solution. It's not, let's build up research, let's build up national testing, let's build up academia testing, let's build up home tests. This must be an end solution. The only way we are going to scale dramatically is by ironing out the logistics, fixing payment, centralizing decision-making, but focusing on all of the testing options as well.
Right. Well, we have a question here, which is very relevant given Mer Suarez's experience, which is this: could you address the issue of COVID-19 immunity and the science that needs to develop there as it relates to ramping up antibody testing, and whether we should be rushing to do those tests if we don't know what it tells us yet about the length of immunity one may have from being reinfected? Because, I think the reason it's so fascinating, someone like Mer Suarez would appear now to be superhuman and able to go forth and do everything that the rest of us can't. Is that true? Dr. Pellini, tell us the good or bad news.
It is an insightful question, and those are questions that still must be answered, and that is the inherent risk to this antibody or serology testing today. There have been 90 different tests, serology tests, that have made it through what is the Emergency Utilization Act for under the FDA, which allowed these tests to come to market very quickly. But there are two types of questions that must be answered with each of these tests. Number one, what is the accuracy of each one of those 90 tests? What is their, do they find the antibodies appropriately? And if they say that they do find the antibody, is it accurate? Does the individual in fact have antibodies? So number one is accuracy, which we still have to sort through. But there's a second issue with these serology or these antibody tests, and that is, even if we know the test is accurate, what does it mean for our immunity? The reason that the Rockefeller Foundation did not focus and has not focused on rolling out serology tests immediately is because we must answer two of these questions. And so what we believe is, by the fall, in order to implement a national surveillance program, we will need broad-based serology testing, and these tests are inexpensive. They can be performed over and over and over again, and in fact, they can be performed at the home. Think about a home pregnancy test. That's basically the same thing if you think from a conceptual standpoint. In order for us to get there, we need to work together as a nation. We need the academic centers to come together, but we certainly need guidance from the federal government, CDC, FDA, and perhaps certainly the NIH, to work together to develop a national strategy to answer the questions that the participant just asked. We can do it. We can do it over the course of a 3 to 4 month period. Understand accuracy of the test and the immunity, and the immunity for each individual in terms of what it means, so we can then roll these out as a nation in the fall. If we don't answer those two questions, it's going to be a free-for-all. We just won't know what we have.
So, Mer Suarez, you may be superhuman compared to the rest of us, but we were not going to find out for a bit yet, unfortunately. So don't relax. But I have a quick question for you, a practical one, and then I'm going to talk to some of the bigger issues to do with national rollouts. But Mer, question from someone from the Pew Fellows program: are there guidelines for family interactions? For example, if you have a young adult in New York who cannot get tested and they want to visit their parents in Miami, what guidelines should be followed? That sounds like one of those questions saying, and I'm just asking for a friend. But right. What happens for everyone who wants to go to Miami right now?
Well, let me start by saying that I took 2 antibody tests. 2 of the 7 were antibody tests, and they both came out negative, which was inaccurate because obviously if I had taken at that point 3 or 4 antigen tests that were 2 of which were positive, 1 of which was inconclusive because the viral load in the cell had already dropped to a level where it was not conclusively positive or negative, and my antibody tests were both negative, then the antibody tests were not accurate, at least according to those who analyzed it for us. So we had an issue to Dr. Pellini's point on point 1. Before we even get to point 2, we had an inaccurate test. So that was the first thing that we had to deal with. If you're coming to Miami from New York, the governor of the state of Florida requires that all travelers from New York be quarantined, irrespective of whether or not they have any symptoms or whether they've tested positive, et cetera, for at least 14 days. So if you're coming to Miami from New York, you're going to have to quarantine for 14 days as if you were in contact or exposed to someone who is positive. That is what the law is right now under the state of emergency of the state of Florida. That's what they'd have to do.
So, memo, take a bag for a long stay, which may or may not be unfortunate at all, but there we go. We have a number of questions about the practicalities of actually rolling this out across the country. A question from Cameron Craig asks, how do you propose to roll this out over the chronically under-resourced and geographically dispersed communities of rural America? And also another very good question he raises, she raises, where do you see potential bottlenecks that could impact supply of testing materials, even if the financial backing is available for testing? Anyone like to jump into that, either Dr. Shah or Dr. Pellini?
Well, why don't I take the rural rollout, and Mike, you take the industry scale-up challenges. The Rockefeller Foundation is partnering certainly with mayors like Mer Suarez and so many others that have responsibility for major population centers, which is sort of the first instinct of an epidemiological strategy for clear reasons. We are also working with rural communities, including with a few states in rural counties and with a few Indian reservations as well. And the reality is we're going to need to do this on a national basis. And that is one of the reasons why having a kind of national action plan, a national strategy, a common reimbursement level that applies at national scale, a data architecture for a testing scale up that is a national database and is openly available to decision makers everywhere, including in rural communities, and a distribution of the call it the AmeriCorps, the service workforce that would make up a community health corps needs to be available and accessible to wherever there is need. And at the end of the day, the triage decisions of how resources are allocated to this effort, especially as it relates to testing and contact tracing, we believe should be at the state level with someone really responsible in every state for a testing and contact tracing emergency operations center like function. And we know that every state has an EOC already, an emergency operations center. We just don't believe that every state has a single individual focused specifically on testing and then taking the data and supporting contact tracing. And that, especially as this pivots into how do we help reopen certain economies, that becomes a critical need. I think Mike can take the other piece of that.
Well, actually, Raj, that really ties in nicely to the bottleneck question. Oftentimes we hear the phrase 1,000 points of light, and that's meant to represent something very positive. In this case, it actually represents something very negative in the sense that if you look to Germany, I think we all have an understanding that Germany has done quite well. One of the reasons they've done quite well is they've had a nationally organized testing supply chain and testing delivery mechanism. All orders from the major diagnostic manufacturers come into one central hub, and then they're distributed. We have these orders coming into 1,000 different groups, thousands of different groups around the nation. And so as part of our proposal, we'd like to at least winnow that down to 50 states. That's a starting point, but 50 is still not a small number in terms of competition. So we're expecting, and we're working with these states to regionalize, and perhaps if we can bring it down to 5 or 6 different regions, that would be another stepwise improvement. Because the question related to bottleneck is, there are many potential bottlenecks here. This supply chain is only as strong as its weakest link. And who in the world thought that we would have ever heard of swabs being a choke point to anything, or a specific reagent being a choke point for anything? And so the best way that we can overcome the known bottlenecks, but also the bottlenecks that we're really not even foreseeing at this point, is to organize. Let's start at the state level, and then let's expand from there. One other point, and this has really become a focus course of the Rockefeller Foundation. There are states like California and Texas that have massive buying capacity. The risk with their buying capacity is that they overwhelm some of the states that don't have the same, let's say, economic horsepower as them. That's another reason why we have to come together into these larger group purchasing regions, so we can in fact compete. Even the city of Miami. If the city of Miami was part of a cohesive statewide plan, better yet, if they were part of a cohesive southeastern United States plan to purchase, better yet, if they were part of a single national plan, every time we can take a step up for buying power, it helps us reduce the risk of these bottlenecks emerging.
In light of that, Mer Suarez, and we're almost out of time, but what is it like actually trying to get hold of the necessary materials on the ground right now in Miami?
We were very lucky. Like I said, our fire chief identified this threat very early on. So we procured things from PPE, personal protective equipment, all the way through tests. We were, and we are a large city in this area. So oftentimes we have more purchasing power. We have the ability to identify things and to act on them quicker. We set up our testing sites. Again, we were the first ones to have in-home testing with our fire department. We have, I think, in our city right now, 3 different ways that you can get tested. There are two sites and one in-home in our city. And we're testing essentially anyone who is symptomatic. So we've had the ability, we've had no shortages, let's put it that way. We have not been limited right now in our ability to test people that are symptomatic. But there are, I mean, that is just a fraction of the population. When you talk about, I think I added up all the numbers prior to this, and I think all of the testing that we've done in the city of Miami residents doesn't even reach 10,000 tests. And we have, again, a population of 500,000. So you're talking about an incredibly large delta between the amount of people that we've tested and the amount of people that are in the general population. They've done some studies, and it'd be interesting to get Dr. Pellini's perspective on this, either on the call or off the call. They've done some studies on random sampling, sort of a polling type mechanism where they randomly sample and test. Unfortunately, I don't think they're doing antigen tests, which they should be, and I think they've been doing them with antibody tests, which I think increases the error significantly. But there are indications that, of course, there is a much greater contagion, either present or past, than we're aware of, and so that also would influence some public policy decisions. And so that's something that's important for us to know from the perspective of having us or fighting against or battling against a second wave of COVID infections and propagations in our city. And unless we do that, what we're doing is we're taking a calculated risk, opening up even with social distancing norms being maintained.
Well, that seems like a fabulous way to sum up what has been a truly fantastic conversation, Mer Suarez. Thank you for speaking so frankly about your story, and thank you for what you're doing to try and set Miami on a better track. And thank you to Dr. Pellini for all of the medical work you're bringing to bear in this field, and Dr. Shah for helping to pull together the different elements of public, private, and philanthropic institutions to support this. I mean, what's clear to me from this conversation is firstly that the capacity to test is there, but it's fragmented, as Dr. Pelini says, in the cottage industry, and we have to professionalize it in a hurry. But secondly, we do have this extraordinary demonstration of the federal nature of the American government, and different cities are experimenting in different ways along with states for both good and bad. But thirdly, as you've heard so clearly, it's going to take a collaborative effort to both streamlining the use of resources, make it more efficient, turbocharge it, and make sure we have both the energy of the private sector, the muscle of the public sector, and also the passion and determination of the non-governmental sector to come together for that. So on that note, thank you. And I'm going to throw to Cathy, who's going to say a couple of words to finish us out. So Cathy, over to you from the Rockefeller Center.
Thank you very much, Jillian. And thank you to our panelists. A special thank you to the Rockefeller Foundation and to Adrienne Arsht, our founder. The time is now. The steps are clear. We look forward to supporting this effort. And as it advances, right now. This is clearly the highest calling there is at this time. We thank you for joining us. And on behalf of the Atlantic Council, you may find this recording if you'd like to share it on the Atlantic Council website, atlanticcouncil.org. And thank you again to our panelists and to Jillian Tett. And we look forward to following through on the next conversation. Thank you for joining us today.